So today we're talking about sleep problems and MS, which is something that actually comes up quite a lot in talking to people with MS. So we're speaking to Dr Kirstie Anderson, who's a consultant neurologist who specialises in sleep medicine. So first of all, Kirstie, could you just introduce yourself and tell us a little bit about what your role involves?
Yes, certainly. So I'm a neurologist who's interested in everything that goes on at night, I suppose. We work in a really large service with sleep labs where we study every aspect of sleep. From a patient's point of view, they only really think of three things probably. Sleeping when it's not enough, insomnia, sleeping too much, not getting through the day without napping, hypersomnia, and then I suppose things that go bump in the night, sleepwalking or bad dreams or night terrors. I might add one other thing to that. I see people who are out of sync with the rest of the world, so real night owls, or for example, people who do shift work, where they're forced out of sync with the natural body clock of being awake in the day and asleep at night. And we would say we can help everybody. We think sleep disorders are easy to treat, but lots of people don't think about them. That's the problem with sleep. You're not really there when it happens, and so people tend to try and force whatever problem they have into a daytime disease, and it could be MS, or it could be anything else. So they often blame feeling groggy and fatigued and sleepy on another problem rather than thinking about sleep. So a lot of what we do is educating GPs and patients and other health professionals to spot the problems in the first place.
First of all, why is sleep so important, and if you're not getting enough of it, what's happening to your body?
So it's a great question. So there's no shortcuts. Absolutely everybody and everything sleeps. It's non-negotiable. We have to sleep. And every night what sleep is doing is a whole host of things. But I tend to teach as the 3 M's. So sleep is really important to regulate mood, memory, and metabolism. So to have normal mood, to have normal levels of happiness, if you like, we need a normal amount of sleep, and it needs to be in the right place. One of the other really important things that sleep does for your brain is to essentially take you offline and to reprocess everything you've learned during the day. So it's not just being awake enough to hear what someone said in the first place. People think about being sleepy during the day, having an effect on attention or concentration. Well, that's true, but it's also new learning. Everything you do during the day is reprocessed, repackaged at night during sleep. So if you sleep badly for any reason, it has a big impact on memory. And the other thing is normal metabolism. So your glucose and insulin are regulated overnight with sleep. So again, if you sleep badly, it impacts on metabolism, and you're a little more likely to be overweight.
Mm-hmm. I think there's a lot of talk on how much sleep people should actually be getting. What are your thoughts on that, and is quality better than quantity?
So the first thing to say is that it's personal to you. There is no such thing as a single number. The 8 hours is a myth. That would be like saying every single person is 5'6". Well, they're not. Some people are 5 foot and some people are 7 foot. So sleep changes over the course of your lifetime. If any of us have had young children, we know that they spend 16, 17, 18 hours a day sleeping when they're newborn. We have teenagers where their sleep need is probably somewhere between 9 and 10 hours. Now, they might not get that, but that's how long they would sleep if you left them without alarm clocks. By the time you get to your mid-20s, you're probably set to where you're going to be for the next few years. So, for example, if you tend to prefer waking up early or going to bed a bit later, if you're a lark or an owl, that's where you'll be set from your 20s. And for most people, the population studies say that we'd sleep about 7.5 hours. Again, that's bringing people into the lab. That might not be the same as the time you turn the lights off or get up in the morning. That tends to decrease a bit over time. So, by the time you are 60 or 65, when we measure healthy, fit, well volunteers in our research, they sleep about 6.5 hours. Mm-hmm. So the key question I ask everybody is, when you wake up, do you feel refreshed? If the answer is yes, you're probably sleeping enough for you. If you don't fall asleep during the day and you awake refreshed, then whatever number of hours you're having a sleep at night is right for you. So don't be put off by other people saying it's 8 or 9 or any other number.
Mm-hmm. So it's really individual to the person.
It's really individual to the person. So it's waking unrefreshed or feeling groggy, sleepy or tired during the day. That's when you start to look at the 24 hours in detail. What time do you go to bed? What time do you get up? Very, very simple. Probably 20 or 30% of people will run a little short. They might go to bed a bit late, busy with children or family or work. They get up a little early. So if you're only having, for example, 6.5 hours of sleep Monday to Friday because you're busy with work, you are going to be sleepy during the day. And sometimes it's incredibly simple. Just write down your life for a week. Let's add up the hours per week that you're actually spending asleep in bed. Mm-hmm. Most people, if they're 25 or 30, if it's consistently less than 7 hours, might be sleeping a little less than they need.
Oh. So, in terms of people with MS now specifically,
yes.
Do you find that that sleep disorders are more common in people with MS than the general population?
Yes. So there's been some nice research studies, and we might pick out a couple of things. Mm-hmm. If we take people who are over the age of 40, then one of the commonest conditions we see is obstructive sleep apnea, OSA. So obstructive sleep apnea in the northeast of England, where I work, is about 10% of men over the age of 40 and about 5% of women. So it's really common. Mm-hmm. Now, by the time you take people with chronic MS, and again, a little older, that's up at about 30%. Mm-hmm. There's all sorts of reasons. If you have MS, you might not move as much as you want and you might have gained a little weight. Mm-hmm. Some of the drugs that people are put on, for example, for nerve pain, can cause weight gain and can make you a little sleepier. So really, really simple questions are, do you snore loudly? You need a bed partner for this. You're not going to know. Do you wake with a horrible sore, dry throat? And do you not get through the day without napping or dozing or sleeping? And then, if you're answering yes to those 3 questions, you need to go and talk to your GP, and you need to just think about the condition in the first place. We have really good treatment. Mm-hmm. We can make an enormous difference to quality of life and quality of sleep treating sleep apnea.
Mm-hmm. And are there any other sleep disorders that you see in people with MS?
So the other one is restless legs, and probably the medical charity that's really useful here is a group called RLS UK. So in terms of just spotting the condition in yourself, they have some lovely simple questions. But people who have a horrible, crawly need to move, need to stretch their legs in the last hour of the night. So sitting down, watching television before you're going to turn the lights out, people who just cannot keep the legs still. Mm-hmm. And it's funny how common restless legs is, but how underdiagnosed it is, even by patients themselves. It's your granddad's legs. Well, restless legs runs in families. It is often the case other people in the family have it. But again, there's an association with any condition that decreases movement. And so people, for example, with spinal MS, who are less able to move, have a greater frequency of restless legs. Really simple lifestyle things help, but medication can make an enormous difference if it's severe. So restless legs, don't label it as an MS nerve pain. If you've got that absolute desire to move, and in fact moving makes the pain better, and it's much, much worse in the evening or the first half of the night, think about restless legs.
It's interesting how it can be kind of associated as nerve pain rather than a sleep problem, and how easy it is to kind of wrongly jump to that assumption.
Absolutely. There's no doubt that I just get patient after patient with very good GPs. We're lucky. We have fantastic GPs who've had a lot of sleep education, but patient gets referred in as insomnia. I think the other common mislabel I would find would be fibromyalgia, where essentially that's a chronic unpleasant pain, but it isn't anything else. For example, inflammatory joint conditions have been excluded, but we go back to the core description. Does this produce a desire to move, and does moving make it a bit better? That's actually quite different to the neuropathic pain of MS, or, for example, nasty osteoarthritis.
So what exactly causes the sleep problems in people with MS?
So we go back to what's the problem. So if we think about insomnia, you might say that's the commonest sleep problem that any GP would see. And by that I would mean trouble falling asleep, trouble staying asleep, and really bothered about it. It impacts the next day. So for insomnia, you don't have to have a reason. It doesn't have to be due to the MS, but it can be triggered by an initial physical or psychological insult. It doesn't always matter. So the sort of thing that would make us all sleep badly, but then it doesn't settle. So for that, you might say it's the initial stress of the MS diagnosis or an initial physical discomfort with an MS relapse. But then essentially the brain gets stuck into a pattern of tuning into the night and doing things paradoxically and not deliberately that actually makes sleep worse rather than better. So if that pattern is something that people recognize, well, my MS has now been well treated with a disease-modifying therapy, but I just can't get back over to sleep, then we would look at a very specific form of CBT, a behavioral therapy called CBTI. And it's really easy to get treatment for this now. There's now treatments out there that are online. There's some very good evidence-based self-help books, and we take patients through treatment. And whether or not they have MS, they would do equally well in terms of knitting together the night. I suppose if I then go back to some of the other physical causes of sleep, if you had obstructive sleep apnea or restless legs, the first thing to do is look at the prescription list, because some of the drugs that are used to treat MS can have side effects of, for example, weight gain, or they might relax the muscles of the upper airway. One of the things that we all do is occasionally have a drink of wine or alcohol, and alcohol late at night can worsen snoring. It can certainly worsen restless legs. So it's worth looking down the list of tablets that you take and the things that you do in the evening. And some of that might be related to your MS prescription, but be something you could discuss with your doctor as adjusting.
And you've touched on this a little bit already, but why do you think sleep disorders are often under-recognised and not properly investigated in people with MS?
Yeah, there's several good reasons. The first thing is, in the United Kingdom, we don't have sleep medicine as its own specialty. So you know, if you have a problem with weakness of a leg, you would go to a neurologist. They would be really well trained to investigate and diagnose MS. But if there's a sleep disorder, we don't have a group of people working within sleep medicine to educate the GP. So we do have a problem with education, and that's different, for example, in America or Australia, where sleep medicine is its own specialty, and the training and the referral pathways are very straightforward. So that's one reason. But if you think about it, the person in front of you is an unreliable narrator, by definition. You know, if you live and sleep alone, how on earth would you know if you have loud snoring? So we have to work a little harder to pick up the diseases. And again, people come to see their doctors in the day. They think about their symptoms during the day. And I think one problem with MS or any other long-term condition is there's a real temptation to blame every symptom on your MS. So, well, you're fatigued. Well, everyone with MS gets fatigue. Well, actually, let's step back a bit. You are waking with a sandpaper dry throat. You do not get through the day without napping. And 5 years ago, when you still had MS, you didn't do that. So the neurologists, again, that I work with, have a really high pickup of sleep disorders simply because they work with me and we discuss and we present the cases. So they've got very good at picking up separate sleep apnea, insomnia, restless legs, sleepwalking, and they don't blame it on the MS. So I think it's having that open mind that it might be another problem.
And if you could give 5 tips for someone with MS to help them sleep better, what would they be?
Oh, that's great. So the night follows the day. Nobody thinks about what they do during the day having a big impact on sleep, but natural light, out-of-breath exercise each and every day makes a really big impact on the night. So we can understand why in 2019 we have sedentary jobs, sedentary lives, and we work indoors. But if I was going to give someone one thing to do to really deepen sleep and improve sleep quality, it would be to stand over them, making sure they do at least 20-30 minutes of anything that gets them too out of breath to finish a full sentence. So it's that simple. When we've done studies like that, when there's been nice research trials, that actually does about as much as a temazepam to get people off to sleep. It's the big thing. So you look at sleep in the round, you look at the 24 hours. So that's the first thing. Anchor point in the morning. So if you're struggling to sleep, if there's long gaps in the night, the temptation is often to lie in bed waiting for sleep. But actually that's the worst thing to do. If you think about good sleepers, if you think about the time when you didn't think about your sleep, you went to bed when you were sleepy and you got up as soon as you woke up. And that's still the right advice. So the key thing to do, get up at the same time pretty much every day. Lying in, wide awake in bed, actually just reinforces the pattern of being awake in bed and therefore bed somewhere that you don't sleep in. And you can sort of see that vicious circle. Tiny thing on coffee, because everybody does the wrong thing with this. Everybody tells me in clinic, my last cup of coffee was, and they tell me the time. We stand back a bit, count the cups. Single most useful bit of advice for coffee is count the cups. If you're up at 4 to 6 cups a day, you essentially have steady state caffeine in the system, because actually your body takes a long time to break down caffeine. 4-6 hours for some people, some a little longer. Some people metabolize it a little slower. So if you are sleeping badly, count the cups. Don't think about the time. And then very simple, 1 cup of coffee in the morning and then we're done. Now, you know, if you sleep well, you can completely ignore my advice. I'm only talking about people who are not sleeping well. So there may be the commonest things that I would go through that people accidentally get wrong, because sometimes actually the sleep advice out there is too generic. It's not personalised enough.
The next question is about fatigue. So fatigue is obviously really common with MS. So could this, if someone's experiencing fatigue, could it actually be a sleepiness that's caused by a sleep disorder rather than MS fatigue?
Absolutely, no doubt about it. While I understand why very kind physical therapists use the word fatigue, unfortunately it's become a really overused word, and what people need to remember is it is a symptom, not a diagnosis. So it's really important. The starting point of someone saying, I feel really fatigued, is to stand back and say, okay, let's actually break that down. There's one of 3 causes. People use the word fatigue when what they actually mean is they are sleepy. Every single person I ever talk to recognizes that if they've been up late for any reason, they're struggling to stay alert the next day, whatever it is they're doing. That is sleepiness. So go back to, can you get through the day without your eyes closing, micro-sleep, the nodding dog? You feel sleepy. Do you mean a physical fatigue? You know, is this someone who really does have significant difficulty moving arms and legs, and they are working hard to maintain their normal activities? And that, of course, you might see in MS. Is it more mental? Is it the sort of symptoms you see with really nasty depression and anxiety? And we should be really upfront about how common those conditions are in any long-term condition that is life-changing. You know, I have, luckily, some fantastic psychiatrists that I work with in the sleep clinic. We see a lot of patients with severe and enduring mental health problems, and they're very clear about how utterly exhausting really severe anxiety or partially treated depression is. But that is different to not getting through the day without sleeping, or a really agitated, wide-awake night where all of your frustration is long gaps in the night. So I think we come back to, do you mean a sleep problem? And the very simple checklist of lights out time, lights on time, a simple check on whether you get through the day without napping usually helps us work out what the cause of the fatigue is and whether it's a sleep disorder.
And so if someone is struggling to fall asleep, what can people try and do to help them actually fall asleep?
So maybe the simplest starting point is to look at your 24 hours. And one of the starting points for us is a sleep diary. It doesn't have to be really detailed, but looking at the lights out time, how long it might take you to get to sleep, what time you get up in the morning, and whether you sleep during the day. And you can jot that down in a very simple format over a week. And people can often look back and spot their own patterns. We then want to separate, is this sleepy or sleepless, or are things happening in the night? For example, sleepwalking, that's actually about 1 or 2% of adults. We haven't really touched on that yet. Are your legs restless? And I think the other thing I would go back to again is, are the drugs that you're taking, that you might be taking for a daytime condition, drugs that affect sleep or wake? And that's a really important point. There's been lots in the press about gabapentin and pregabalin. Now, there is good and bad to every drug. Those are drugs that are very good, for example, for restless legs if they're taken once a day in the evening, but they are drugs that cause sleepiness. So if you take them in the morning, there may have to be a trade-off between treating pain but being sleepy. And as long as people understand that, you empower the patient to make the right choices about the balance of medication. But I think understanding exactly what they do and how they work is really important, because I see patients who say, no, I was never told that pregabalin would make me gain 2 stone, and that's just worsened my back pain. Now, if you're told, you can stand on the scales, you can calorie count, you can watch your weight, and you don't lose control of it, and frustrated 2 or 3 months later, you've gained the weight. So it's just all about a good explanation of what drugs do to sleep and wake, as well as what they're going to do, for example, for nerve pain.
Some people find that they do fall asleep, but they keep waking up during the night. So what can people do if that's a problem?
So for a start, we say, is it normal? So one of the most useful things that my insomnia patients hear is that everybody wakes and nobody sleeps through. So it's such an important thing to say to people, that normal sleep is taken in chunks. Absolutely nobody, the best or the worst sleeper in the world, sleeps through uninterrupted for 7 or 8 hours. When we bring people into the lab, we can see that about every 90 minutes or so they wake. Now, they may wake for a short time, or they may wake long enough to remember it, but they all wake. So we spend a little bit of time just explaining normal sleep, the changes over time, and the fact that you take sleep in chunks. And what we're really dealing with insomnia is not the wakenings, but becoming cross and bothered about the awakenings, which is a different thing. So when we explain to people, you will wake, and that's normal, but what are you doing when you wake up, and how can we get you to return back to sleep quicker? And again, that's where the diary comes in. Is there a physical cause of wakening? You might gasp or snore, or have a problem that relates to breathing. Are the restless legs driving you crazy? Do you have a problem with your bladder? Very common in MS. Are you waking up to pass urine 6 times? Well, then we're going to need to look at medication, we're going to need to look at diagnosis. Or is there no particular reason for waking, but when you wake up you are really cross, mind racing, but you're staying in bed? Well, then we're going to look at behavioural techniques. And the first thing you're going to say is you take the agitation out of the bedroom. Really consistently, if you are wide awake, flinging the duvet around, wanting to stab a peacefully sleeping partner next to you who's snoring away, that what you do is you take that out of the bedroom. You don't lie there stewing. You head out of the bedroom, read, music, word search, it doesn't matter. You head out of the bedroom until everything is feeling sleepy and relaxed again, and then back in. It's quite hard advice to follow, but when we do it with sleep diaries, you see it working. You see those night wakenings get shorter and shorter until they're only 5 or 10 minutes. And then we say, actually, you're normal. You are having 3 to 4 chunks of about 90 minutes of sleep, and that's what the rest of the world is doing as well.
It's really interesting, actually, kind of educating people on what sleep actually means and how it works in the night, and it is in chunks rather than one continuous...
Absolutely. It's a really interesting thing that people look up on the internet. Of course, that's what I do to get my information. But some of the absolute basics of making people their own sort of sleep experts, it really is the most useful thing that we do when we put people through our 6-week sleep therapy groups, where we'd expect about 80% of people to be much more comfortable with sleep and to be sleeping better. And for us, it doesn't matter. They can come to see us with MS, they can come to see us with chronic pain, they can come to see us with any other long-term condition. If they're agitated about insomnia, we'd expect to help in exactly the same way.
And so you did touch on it a little bit when you answered the previous question, but do people with MS need to be aware of MS symptoms impacting on their sleep?
Definitely. So I suppose I might go to bladder. So I tend to say that if you're under 20, you really would not expect to pass urine during the night. By the time you get to somewhere between 30 and 50, it's quite common to get up to pee once. Many men over the age of about 45 or 50 will get up to pee once or twice and will rapidly return to sleep. But if you're getting up desperate to pee 3, 4, 5 times at night, that's a very annoying physical cause of sleep disruption, and you would want to be talking to your MS doctor or your GP about ways to treat that. So that would be very high up the list as something that's a physical cause of trouble. I think in terms of the medication that you're on, lots of the MS drugs tend to actually make people a little, in terms of drugs, for example, to treat pain, might improve rather than worsen sleep. So it would be unusual for drugs to worsen sleep outside of steroids. I think a lot of people may have had a course of steroids. They really do cause insomnia for most people. So if you are having a course of steroids, it would be great to try and take the dose in the morning. Otherwise, you might expect difficulty sleeping on the night that you've taken the steroids.
And we spoke about fatigue a little bit earlier. So if someone is experiencing MS fatigue, is it a good idea to sleep more during the day and try and combat the fatigue, or would that kind of negatively affect your sleep routine?
So again, it depends a little. If the problem is insomnia, so if somebody perceives that they have a racing mind, they take a long time to fall asleep and they're awake for long periods of time, then the advice tends to be not to nap during the day, because you are saving the sleep for night. You are wanting to build up a pressure to sleep. So it's a bit like food, for example. If you have a snack just before your main meal, you're not going to be hungry. If you fall asleep on the sofa at 7 o'clock watching the soaps, you are less likely to fall asleep at 11 at night because you've already had a nap. If, on the other hand, you really are sleepy and tired, and particularly, for example, if you drive and you want to make certain that you are alert behind the wheel, then some people will get benefit from a power nap. But if you're going to do that soon after lunch, to give yourself enough time to then get sleepy again at night, and you tend to want to keep that short. Most people will get benefit from, say, 20-30 minutes. If you sleep longer than that, a lot of the time you're going into deeper sleep stages and you feel quite groggy when you wake up. So again, it's personalised. If somebody says to me, I find a 30-minute nap after lunch really good, I can do more in the afternoon, and I still sleep well at night, well, they're doing the right thing. If someone has bad insomnia, we would generally say don't go into the bedroom during the day and don't sleep during the day, otherwise you're not going to sleep as well at night. So again, coming back to the patient in front of you and what the problem is. Does that make sense?
And in terms of medications, I think you have mentioned a few already, but are there any that can affect sleep?
Yes. So we go, some of the anti-sickness tablets, occasionally used to combat side effects of drugs. So in particular, a tablet called metoclopramide can aggravate restless legs. In terms of the disease-modifying therapies, most of them don't have a big impact on sleep. So that's a relatively straightforward and quick question to answer. The steroids we've talked about, they tend to be alerting and aggravate insomnia. We've talked about, I suppose, drugs like pregabalin and gabapentin. So pros and cons to those drugs. They do cause sleepiness, and that can be a really good thing at night. They're good drugs for anxiety. They are bad drugs for daytime sleepiness if you are already sleepy, and they're very good drugs for nerve pain. So, of course, you might sleep better at night because you don't have nasty nerve pain. Amitriptyline, because it's such a widely used nerve pain drug, pros and cons, amitriptyline can worsen restless legs a little, and again, it stays in the system a long time. So a lot of people feel groggy when they first wake up in the morning and they have dry mouth. And actually, it's not great to have dry mouth. You can wake up parched, wanting to drink water. So it's a real balance of what the drug has done. It will help sleep for some. If you have restless legs, it might make it a little worse, in fact, and it stays in the system a long time. and so you may feel hungover and a bit groggy taking it in the morning. So it's understanding your schedule and what it does to you. And I think that they're widely used drugs within MS clinics to combat some of the symptoms. Baclofen might be the one to mention as well. Baclofen, used for spasticity, good drug for pain, good drug for deep sleep, but again, side effects of daytime sleepiness are common. So you need to build up, you need to work out the balance between not feeling too tired and sleepy due to the drug and how much it's doing to improve the spasticity. And there's sometimes a reason to give a little more drug at night in terms of baclofen, so the legs aren't juddering and shaking on you, and that's incredibly annoying, so you get a better night's sleep, but you might not be able to take quite as much during the day because then you're not awake enough to do your physio or to move out and about and to do the other things that help spasticity.
So it's getting the balance right, really.
Agree, yeah.
So finally, how should sleep problems in MS be properly investigated and treated?
The first thing is to think about the type of problem that you've got. So, are you struggling to stay awake during the day? In which case, the best thing is really to discuss either with the nurse specialist, your consultant, or your GP, looking down the prescription list, thinking about snoring, thinking about restless legs, and really the issue is often going to be referral to a sleep service for an overnight sleep study. And just to reassure though people, most of those are done at home and in your own bed. I think a lot of people think of the sleep lab as quite invasive with lots of wires on, and it's a nuisance to come into. So we do inpatient video sleep studies, but probably only for 5 to 10% of all of our patients, and about 90% we can diagnose with home-based tests. I think we'd go the other way and say if it's insomnia, that may not be anything specifically to do with your MS, and it may be in and of itself something that's straightforward and easy to treat, and a lot of the time you talk to your GP first about that. I think if it's things that happen in the night, if it's some form of violent or dramatic event, that is one of the times where you might need an inpatient video sleep study, particularly if either you're hurting yourself or your partner's getting hurt. So I think that's something where you'd flag up, not blaming it on the MS necessarily, and talking to either your specialist or your GP about coming to see somebody like me.
Yeah, I think there's definitely a lot of people do blame everything on their MS, and that does happen a lot, and people don't look outside of the box and think, oh, there could be something else going on here.
Yes, there's a small list of sleep disorders. Almost all of them are treatable, and if you've established that it wasn't a treatment that your MS doctor put you on that caused the trouble, you would stand back and think again, and that very simple, measure, sleepy, sleepless, things that go bump in the night, and we might sort of squeeze restless legs into that. Which of the three problems is it? And then work out the best treatment.
You mentioned sleep services and being referred into one of those. I was just wondering, in terms of kind of the services in the UK, are they kind of fairly well spread out? Are there a lot of services kind of covering all areas, or is it a bit patchy?
Well, in terms of respiratory sleep service to screen for sleep apnea, which is by far the commonest sleep disorder that's treated in a hospital rather than by a GP, there are over 300 services, the length and breadth of the country. So every GP will have the ability to refer in for a respiratory sleep study to screen for sleep apnea. So that's quite straightforward. Most GPs would look at insomnia and do things in primary care first to try and help. In terms of services like ours, no, there's fewer of those, but there's still well over 20, and we certainly see, for example, people from throughout the entire northern region. So most regional sleep services would absolutely accept referrals from a very wide postcode range, because we accept it's a little like, a large neurology service. We see beyond just the immediate postcode. And the services are increasing a little. There is an issue with waiting lists. As I said, some of that comes down to not having sleep medicine as its own specialty. But I think there's an awful lot that patients can do to help and treat their own sleep in terms of getting access to simple evidence-based things already out there. For example, NHS choices. I regularly check the information, and the information on NHS choices on all of the sleep disorders is very good. it does give patients excellent evidence-based advice about how to start to work out who they need to see about the problem.